Welcome to The Explainer. All right, today we are tackling a huge topic, endodontic pain. We're basically creating the ultimate study guide for you. We're going to break down all the core science and the clinical strategies you absolutely need to know, all in one clear, structured explainer. The goal? To help you crush your exams and, of course, be a rock star in the clinic.
Okay, so here's our game plan. We've laid this out to follow a patient's entire journey. We'll start with the basics. What is a pain signal? Then we'll follow that signal down the nerve. After that, we dive into the tricky stuff like anesthesia challenges. And finally, we'll cover how to manage pain before, during, and after the procedure. Think of this as your roadmap for the next few minutes.
All right, Section 1. First things first, we've got to lay the groundwork. You can't really manage pain, not effectively anyway, if you don't get what it is at a basic level. So whether you're prepping for an exam question or you're chairside, you need to know how that signal gets from point A, the tooth, all the way to point B, the brain.
So let's start with the book definition, right? The International Association for the Study of Pain calls it an unpleasant sensory and emotional experience. And those two words are key, sensory and emotional. That's a huge point because it reminds us that what the patient feels isn't just about the nerve firing. Their anxiety, their fear, their past experiences, that's all part of the pain package.
So how does that pain signal actually make its journey? Well, you can boil it down to three main steps, and this is perfect for exam recall. First, you have detection. That's when the pain receptors, the nociceptors, realize something's wrong. Step 2 is transmission. That's the signal zipping along the nerve fibers, kind of like a message on a highway. And finally, Step 3 is processing, where the brain gets the message and goes, ouch, that's pain. Detection, transmission, processing. Got it? This pathway is fundamental.
Okay, so we know the signal travels down a highway. But what kind of cars are on that highway? Well, that's where we get into the message carriers themselves, the nerve fibers. And this is so cool because the type of pain your patient describes, it tells you exactly which nerve fibers are firing off. This isn't just textbook stuff. This is straight-up diagnostic gold.
Okay, listen up, because this slide is a classic high-yield exam question, the A delta versus C fibers showdown. Think of it this way. A delta fibers are the sprinters. They're fast, lightly myelinated, and they deliver that first pain. That sharp, quick, bright zing you get from a blast of air. Then you have the C fibers. They're the marathon runners. Unmyelinated, slower, and they carry that second pain, the dull, throbbing, aching pain that just lingers. So sharp first pain, A delta. Dull second pain, C fibers. Easy.
So, we've covered the basics of the pain signal. Now let's pivot to the real world, to the clinical challenge. We've all been there, right? You give the injection, everything seems fine, but the anesthesia just fails. Why? Why does our #1 tool for pain management sometimes let us down right when a patient needs it most? Getting this is crucial for troubleshooting on the fly.
And here it is, the million-dollar question. Why is it so dang hard to anesthetize a hot tooth? You know the one, the tooth with irreversible pulpitis that just will not get numb. It's probably one of the most frustrating things we deal with in endo. So let's get into the science of what's actually going on here.
So what's the deal? Well, it's not just one thing. Inflammation is basically launching a full-on assault against our anesthetic. First off, the tissue gets more acidic, the pH drops, and that literally traps the anesthetic molecule outside the nerve, so it can't even get in to do its job. Then you've got increased blood flow to the area, which just washes the anesthetic away faster. And here's the kicker. The nerves themselves actually change. They get hypersensitive, and they start expressing these special sodium channels, these TTX-R channels, that are way more resistant to local anesthetics. It's a perfect storm.
And look, this isn't some small insignificant problem. This number says it all. 8 times. The failure rate for a standard inferior alveolar nerve block is 8 times higher in patients with irreversible pulpitis. That is a massive number. It really drives home how big of a deal this is clinically. Definitely a statistic to have in your back pocket for an exam.
So what do we do about it? Well, this leads us to a really important idea. Pain management doesn't start with the needle. It actually starts before the patient even gets in your chair. Let's talk about the smart, evidence-based strategies we can use to set everyone up for a much better experience. Okay, this pathway diagram looks complicated, but the concept is super important. When there's tissue damage, the body kicks off this chemical cascade. The end result is the production of prostaglandins. Now, prostaglandins are bad news for us. They don't just cause pain, they actually make the pain receptors more sensitive, kind of like turning up the volume on them. So what can we do? We have the patient take an NSAID, like ibuprofen, about half an hour before we start. The NSAID blocks these COX enzymes right here, stops the prostaglandin party before it even starts, and prevents that hypersensitivity. It is literally a preemptive strike against pain.
All right, fast forward. We're in the middle of the procedure, we did our pre-op management, we gave our best block, and the patient still feels it. What now? This is where you absolutely have to have a solid plan B, C, and D. So let's run through the essential supplemental techniques to get that profound numbness we need.
And here's another one of those classic clinical puzzles that's also a favorite exam question. Your patient says, "Yep, my lip is totally numb." You feel good, but then you go to touch the tooth and they jump out of the chair. So what gives? Why is the lip numb but the tooth isn't?
The answer goes right back to our nerve fibers. A numb lip just means you've successfully blocked the A-beta fibers, the ones that handle touch and pressure. But the pain, the real pain from the pulp, is carried by those A-delta and C fibers we talked about. And shockingly, even with 100% lip numbness, studies show the actual pulpal anesthesia can be as low as 40%. The big takeaway here, a numb lip is not a reliable sign. You have to confirm with an objective test, like a cold test or an electric pulp tester, before you even think about starting.
Okay, so your block failed. What's your first go-to? For many, it's the intraligamentary or PDL injection. You're basically forcing the anesthetic right into that PDL space. The best part, it works almost instantly. The downside, it doesn't last long at all, maybe 10 to 20 minutes. So if you're going to use it, you got to be ready to work fast.
Another really powerful tool in your arsenal is the intraosseous injection. This one is clever. You deliver the anesthetic directly into the spongy cancellous bone right near the apex of the tooth. By doing that, you completely bypass all those problems we talked about, the low pH, the inflammation, all of it. This is why it has such a high success rate, especially for those really tough, hot teeth. And then there's the intrapulpal injection. This is often your move when nothing else has worked. You're injecting directly into the pulp chamber itself. What's interesting is the anesthesia comes from the sheer pressure you're creating. It works instantly and it's profound. It will give you just enough time to get in there and remove the pulp tissue. But you have to be honest with the patient. It can be really uncomfortable to give, and the effect is super short-lived. It's a quick, effective, last-ditch effort.
So, you made it through. The procedure's done, the pulp is out, high five. But wait, we're not finished yet. Our job isn't over. How we manage pain after the appointment is just as critical for our patients. So let's talk about the best strategies for post-op pain control.
So, why do patients have pain after a root canal? Well, it's mostly due to the acute inflammatory response from the procedure itself. It's totally normal. And since the problem is inflammation, it just makes sense that our solution should be anti-inflammatories, right? So NSAIDs are our first line of defense. And even better, studies have shown that if you combine ibuprofen with acetaminophen, you get a powerful 1-2 punch that works even better than either one on its own.
Okay, and now for what is maybe the most important takeaway in this entire explainer. Seriously, if you remember one thing for your exams about post-op care, let it be this. Do not use antibiotics to manage post-operative pain. I'll say it again. Antibiotics are not painkillers. The pain is from inflammation, not a systemic bacterial infection. Giving antibiotics for routine post-op pain is just wrong. It doesn't work, and all it does is contribute to the terrifying problem of antibiotic resistance. And that really leads us to this final thought. As this problem of antibiotic resistance gets worse and worse, we have to really think about how we manage dental infections and the inflammatory pain they cause. It's on us, as clinicians, to be smart, to be good stewards. That means using the right tool for the right job, anti-inflammatories for inflammation, and antibiotics only for bacterial infections. And that's a wrap on our deep dive into endodontic pain. I really hope this guide helps you lock in this material, not just for your exams, but for taking the best possible care of your patients.